All right, let's dive into a high-yield topic you'll see all the time, peripheral artery disease. In the next few minutes, we're going to go beyond the textbook to really understand why this is so much more than just leg pain and how you can actually change the game for your patients. So, let's kick things off with a big number, 10%. That's right. By the time someone hits 70, there's about a 1 in 10 chance they have peripheral artery disease. This isn't some rare, exotic diagnosis. It's something you're going to see in your clinic day in and day out. And this is exactly why that 10% is so important. When you diagnose PAD, you're not just finding a leg problem. You're seeing a huge flashing red light for systemic atherosclerosis. These patients are at a much, much higher risk for heart attacks, for strokes, and for death. Recognizing PAD is our big chance to step in and totally change their trajectory. So, to really get a grip on this, we're going to walk through it just like a real clinical encounter. First, what exactly is PAD? Then, how do we find it? Screening and presentation. We'll cover the workup, how to manage it medically, when to call for an intervention, and we'll finish with the one thing you absolutely cannot miss, the true limb-threatening emergency.
Okay, so first things first, when we're talking about PAD, what are we really talking about at its most basic level?
At its heart, PAD is just atherosclerosis, but in the legs. It's the exact same plaque buildup you find in the coronary arteries or the carotids. And the risk factors? Well, they're the usual suspects. Smoking is the big one for sure, but also diabetes, high blood pressure, high cholesterol, and of course, just getting older. So we know what it is. Now, how do we actually find it? Let's talk about who we should be screening and what these patients look like when they walk through your clinic door. Now, right away when it comes to screening, you run into a classic clinical gray area. The major cardiology societies say, yeah, it's reasonable to screen at-risk patients with an ABI. But then the USPSTF comes along and says, well, we don't think there's enough evidence to say yes or no. This is a perfect example of where your own clinical judgment is going to be key. And this chart shows you exactly why screening is so tricky. A huge chunk of patients with PAD have absolutely no symptoms. That textbook intermittent claudication, the classic cramping pain with walking, that's only about a quarter of them. And the really severe form, chronic limb-threatening ischemia, is thankfully pretty rare, less than 5%. So, your patient story has you suspicious. What's next? Let's get practical and walk through the actual diagnostic workup. One of the biggest red flags on physical exam is an arterial ulcer. These things have a classic look. You'll find them way down on the toes or the foot. They look punched out with really sharp borders, and the base is often dry and pale. And let me tell you, they are usually very, very painful. It's a direct sign that the tissue just isn't getting enough blood. But the real cornerstone of diagnosis is the ABI. It's so simple, it's non-invasive, and it's incredibly accurate. It's just a 4-step process. You have the patient lie down and rest, you get the systolic blood pressure in both arms, then you get the pressure at both arteries in each ankle, then you just do the math. For each leg, it's the highest ankle pressure divided by the highest arm pressure. That's it. And interpreting it is just as straightforward. Here's the money number. An ABI of 0.90 or less is diagnostic for PAD. A normal ABI is between 1.0 and 1.4. And this is a huge clinical pearl. Pay attention to that top number. If you get an ABI over 1.4, it doesn't mean the arteries are wide open. It means they're calcified and non-compressible, something you see a lot in patients with diabetes. That result is basically uninterpretable, and you'll need to get a toe brachial index instead. Okay, so you've made the diagnosis. Now we pivot to management. And really, we have two main goals here. 1, slash that patient's cardiovascular risk, and 2, help them feel better. The absolute foundation of treatment is getting those risk factors under control, and I mean aggressively. Number 1 with a bullet is smoking cessation. It is the single most important thing they can do. Beyond that, every single one of these patients should be on a high-intensity statin, have their blood pressure locked down, and if they have diabetes, they should be on a drug with proven cardiovascular benefit. Now, when it comes to antithrombotic therapy, the COMPASS trial really did change the game. What it showed was that adding a small dose of rivaroxaban to aspirin significantly cut down on both heart problems and major limb problems. Now, what's the catch? Well, there's a higher risk of major bleeding. This is where you have to sit down and have a real shared decision-making conversation with your patient about the risks and benefits. Now let's talk about symptoms. The number 1 first-line therapy isn't a pill. It's supervised exercise training. It has been proven over and over to be the most effective thing we have to improve how far these patients can walk and how well they can function. It's so effective, in fact, that it's now covered by Medicare here in the US. If exercise just isn't cutting it, you can consider a trial of a medication called silostazol. It can help improve walking distance, but, and you absolutely must burn this into your brain, it has a black box warning. It is completely contraindicated in any patient with heart failure, no matter how mild. But what happens when you've done all the right things with medical therapy and it's still not enough? When is it time to escalate care and think about an intervention? The reasons to call for revascularization are actually very clear, and it's important to remember we do not intervene on patients without symptoms. We escalate care for two main reasons. Either their claudication is so bad it's limiting their life and hasn't gotten better with exercise and meds, or they're showing signs of tissue damage, pain even at rest, ulcers that won't heal, or gangrene. Those last three, that's chronic limb-threatening ischemia. And that brings us to our final and honestly our most important section. This is the real deal, the true vascular emergency that every single one of us has to be able to recognize in a heartbeat: acute limb ischemia. And here's why it's so critical. The outcomes are just grim. Within 1 year of one of these acute events, you're looking at a 10 to 15% amputation rate and a 20% mortality rate. This is not just about saving a leg. You are trying to save a life. You have to remember, time is tissue and time is life. So how do you spot it? The classic mnemonic is the 6 Ps. The limb is going to have intense pain, it's going to look pale, you won't be able to find a pulse, pulselessness, the patient will complain of numbness or tingling, paresthesia, it'll be cool to the touch, that's poikilothermia, and in the late stages, they'll develop paralysis. If you see even one of these, alarm bells should be screaming in your head. Your response has to be fast and decisive. Step 1, get that patient on an IV heparin drip immediately to stop the clot from getting bigger. Step 2, get vascular surgery on the phone, stat. Step 3, start preparing the patient to go for an angiogram to find the blockage and figure out how to open it back up. Every single minute counts. So, let's end here. Knowing the 6 Ps is absolutely critical for managing a crisis in the moment. But the real challenge, the one for all of us, is this. How are you going to use everything else we just talked about, the screening, the early diagnosis, the aggressive risk reduction, to make sure your patients never even get close to this devastating stage?